Good afternoon. My name is Mary Catherine Stamey. I am a rising second-year medical student at the Mercer University School of Medicine. I'm also a Maternal Health Observership Scholar for this summer. It's my honor to introduce to you Dr. Stephanie Singleton. Dr. Stephanie Singleton is a 1999 graduate of Mercer University School of Medicine in Macon, Georgia. She completed her residency in obstetrics and gynecology at the University of Tennessee in Chattanooga, followed by a continuation of her training through her fellowship in reproductive endocrinology and infertility at the Jones Institute for Reproductive Medicine at Eastern Virginia Medical School. She is double board certified in both obstetrics and gynecology as well as reproductive endocrinology and infertility. She was named as a fellow of the American Congress of Obstetrics and Gynecology in 2009 and is currently working as an assistant professor within the Department of Internal Medicine at Mercer Medicine Putnam County in Eatonton, Georgia, as well as serving as the president for her family's company, Silt Saver Incorporated. Please join me in welcoming Dr. Stephanie Singleton.
Thank you for that kind introduction, and I appreciate the opportunity to be here with you today. An interesting topic for me to be talking about menopause. I will admit that the majority of my career was spent taking care of reproductive age women. Several years ago, my husband and I decided to make some life changes, move back to Georgia, and moved to Eatonton, Georgia. At that time, I was going to retire from medicine and run my family's company, which is a completely different area, and went to see my new internal medicine physician at the local Mercer clinic, who informed me that they really needed some gynecologists in the area. At that time, they had one full-time gynecologist, one part-time gynecologist, and many people moving to the area. So I thought, I can do this. I haven't done a pap smear in many years. I did a lot of embryo transfers and things like that. But, you don't, one of those things like riding a bike, I can go in, one day a week, I can do some pap smears. So I signed up for it. I went in and started seeing patients and remembered that in Eatonton, Greensboro, Georgia, it is predominantly a retired community. So the lakes are there. It attracts a lot of retired individuals that want to come there and do boating and various things. And so I went to work to my pap smear clinic and discovered that 95% of my patients were menopausal or most actually postmenopausal, and most of them didn't even need pap smears. So then I discovered menopausal care and postmenopausal medicine, which was something that honestly I don't remember us spending a lot of time on in even residency or in fellowship. And so I think, hopefully today I can present a smattering of topics that are important to these ladies and to many of us as we mature, because I think this is a topic that hasn't been talked about a lot in the past, even in our field and in our communities. I think maybe in the past women were not as open to speaking about the changes of menopause. They just kind of tucked them under their belt and, sucked it up and kept going. And now we are a much more outspoken generation and more comfortable about talking about our sexuality and the things that are happening to us. And so I think more and more you're going to have patients that you see in your clinics and in your offices that are asking you those hard questions and are presenting with, what is going on with me? Just like I am. And these are educated, intelligent women. I'm seeing former CEOs of companies, former researchers from the CDC, and they're coming in thinking that they have some horrible disease process when in actuality they have menopause that is happening. And it's amazing to me now that I'm seeing these women. I think that we're doing a really good job now of preparing young women, that you're going to see some hormonal changes about to happen when you hit your teens. These are going to affect your body. You're going to see some life-changing events start to occur, and we can give you support and answer your questions and help you to have options about how to address these issues. We now need to start doing the same thing for our mature ladies. You're going to see some hormonal changes. They're going to cause changes in your body. You're going to have some life-changing events happen, but we can give you support and we can talk about your options for treating them. So hopefully we'll talk about some things today that can be helpful, some things that your patients may be asking you, and some things that you may need to be asking your patients. So I'm joining the old lady club. So back to my glasses here. So what is menopause? This is something that is even confusing to patients because they think menopause is when they have a hot flash. And in actuality, the definition of menopause is that permanent cessation of menstruation, and it's when it occurs for 12 months. So 1 year, no menses. That is, in actuality, the definition of menopause. Typically, in American women, this is going to hit around age 50, 51. We know that in some women, they're going into menopause earlier. These symptoms of menopause can actually last 7 to 14 years. So in the United States now, life expectancy, approximately 81 years of age. This means that women can be in this menopausal, postmenopausal state for about 3 decades. That's a lot of GYN visits, a lot of questions that you might be faced in to answer. What causes menopause? Hopefully you know by now that's a lack of functioning of the ovaries, and we see this in the dropping in the estrogen levels, the dropping testosterone levels, dropping progesterone levels. This does show the elevation of the follicle stimulating and luteinizing hormone, which are kind of a consequence of that as the hypothalamus tries to compensate. And when we think about the female hormones and what they do, some of the symptoms of menopause make sense. So estrogen stimulates growth of the breast, maintains that vaginal blood flow and the lubrication, causes the lining to thicken during the cycle, results in vaginal lining being more elastic, maintains the bone, maintains the muscle mass. When we start to lose these things, then not surprising that we start to see some of the issues and the symptoms that our patients present with. And we recognize that no, these are not disease states. This is part of that natural maturation process. So to talk about one of the major symptoms of menopause, and this one most of you are hearing about more in the news right now because there have finally been some developments and some new medications that we'll talk about. But the vasomotor symptoms, that's your hot flashes, the thermoregulatory heat dissipation events. Basically, you get really hot and you feel like you're on fire from the inside out, and it's occurring in your face, in your shoulders, in your upper body predominantly. And some women become red in the face, other women can conceal it better. It is uncomfortable. And for those of us obstetrician gynecologists that have studied this your whole life, you still never really understand it until you're there. And then you have a whole new appreciation for what a hot flash is. So with this, we do see it associated with lower estrogen levels, higher FSH. We know that it's a time when that neutral thermoregulatory core becomes more sensitive. So meaning that when we're exposed to smaller amounts of heat or cold, we respond in a much greater way with either chills or sweating, and it can create a very uncomfortable cycle where you're sweating and you're hot 1 second, and so then that turns into chills the next cycle. So it's not even just the hot flashes that are miserable, it's the hot flashes and the cold flashes. And you'll hear all of this from your patients. Studies show that about 60 to 80% of women experience these at some point during menopausal transition. Typically, we see them the worst actually during perimenopause sometimes and the beginning of menopause. And for some women, they don't have them at all. For some women, they get better with time. 87% of women experience these symptoms daily. 33% have greater than 10 hot flashes in a day. So some women will tell you that they feel like certain things trigger them more than others. And again, this is real. These are not just, this lady complaining, and it's not just, fighting with her husband over the thermostat. We know the science proves these things are really happening, and they can be debilitating to our patients. For women that do presentations and they're sitting in front of a crowd, and I may have one any minute, for trying to accomplish sleep during the night because you need to operate the next day. They're important, and women need you to listen to them and to talk to them about their options. SWAN, the study of women's health across the nation, looked at things that can predispose women to having more hot flashes, or those women that tend to develop hot flashes more readily. They found that they were more commonly reported in the African American population, less commonly reported in the Asian population. Now, some hypothesize that maybe this is related to soy in the Asian diet. Maybe they don't have as many hot flashes. They found that that was not the case. They felt like maybe it's a cultural difference. Maybe Asian women don't actually report. Maybe they're having the same number and they're not actually reporting, and that may yet be the case. They also saw an association with obesity. So at first we thought that adipose might be protective. We know that adipose can produce estrogen, and so we thought maybe those women that are heavier would be less likely to have hot flashes, but unfortunately not the case. It actually seems to act as more of an insulator dealing with those thermoregulatory events. And so we see that obese women tend to have hot flashes more readily. Smoking, another factor. We've heard several times from several speakers all the different reasons that our patients should stop smoking, and maybe finally in menopause we can get them to stop, because the studies show that women who smoke are 60% greater, have a 60% greater chance of developing hot flashes than women who do not smoke. We don't know if this has to do with a failure of the ovaries. I can tell you from my fertility history that we tended to see that women had bigger issues or greater issues producing eggs and with ovarian function if they were smokers. It may be the cause. They have not yet proven that. Again, we need more and more research in this area, but certainly smoking, greater chance. And it's also going to limit their options for treatment. SWAN looked at the associated quality of life symptoms. They also found that sleep disorders, of course, were associated with hot flashes, and this has both to do with the continuity and with the quality of sleep. Not hard to believe for women who have experienced this. They found that depression and even more so anxiety was related to vasomotor symptoms. And so women who were depressed prior to menopause, again, more likely to develop vasomotor symptoms in menopause. Not every woman who's depressed has hot flashes. Not everyone who has hot flashes has depression. They also found in some studies that there was an actual time period during menopause where it was harder for women to learn. This wasn't backed up by all studies, but they did show this in several studies, and they did recover from this after menopause, or after those initial years of menopause. So truly, when patients come in and say, I'm having hot flashes, this is debilitating, there's truly science behind that. So how do we help them? The first line of treatment would be systemic hormone replacement therapy. And I think we have gained some mistrust by the public in the past, because I know, when I initially started training, we gave everyone hormones. And then the Women's Health Initiative tried to show how helpful hormones were to coronary and vascular disease, and failed miserably, and found that actually, they can contribute to disease. And so then we took everyone off of hormones, and now we're back to kind of a midway spot that you actually have to take a lot more time with your patients now. Look at their family history, look at their personal history, look at their health habits, ask them about their life history to decide if they are candidates for systemic hormone replacement therapy. It can be administered orally or transdermally. we know that it should be administered in the lowest effective dose for the shortest duration. So give them the medication or give them the hormones to address the hot flashes. When they are through that period of symptoms, then take them off of the medications. The greatest risks with the systemic hormone replacement therapy that they noted with the WHI are going to be breast cancer, your coronary heart disease, your stroke, and your venous thromboembolic events. And one thing that I've noticed with my patients, and hopefully you'll remember this, is when you ask patients about their medical history, they don't tend to tell me about blood clots unless I specifically ask that. If you ask them, have you ever been diagnosed with a blood clot in your leg or in your lung, then they'll say, oh yeah, I had that and my dad had that. But that's not something that they tend to write on their medical history. So very important to know if you're looking at systemic hormone replacement therapy, because they don't need it or shouldn't get it. Side effects from some of the hormones would be breast tenderness, vaginal bleeding, bloating, and headaches. But for the most part, this is a very effective means of treatment in the right candidates. It can work within a few days and really make a difference with their symptoms. It does not need to be monitored with hormone levels, and we'll talk a little bit more about that in a second. But this should be monitored with their symptoms. So when you're trying to decide on the dosage, start with the lowest, and then if they're still having the symptoms, you can go up on that dosage. But bringing them in to check their estrogen levels, to check their progesterone levels is not necessary and is not supported by the research. So then if you're talking about hormone replacement, there's the whole other discussion about and the confusion about bioidentical hormones and compounding pharmacies and the multitude of options that are very confusing to both patients and physicians. The things that patients think about bioidentical sounds and has been promoted as being much, much safer and more natural. And especially, again, following the WHI studies, a lot of people are afraid of hormones, and so they think, well, that for sure has to be the better thing. And it has not proven to be safer than the synthetics. So synthetics, different from bioidenticals in their source, both made in the lab. So neither one, you go out and pick off a tree. Both are made in the lab. It's simply the initial source that it comes from. Bioidenticals come from plants. Synthetics come from chemical compounds. Synthetics are always going to be FDA regulated. So remember, FDA regulated medications are those that should be the same from any lab, should be the same in every tablet that you administer or you take. If it's not FDA regulated, then that is not guaranteed. And so bioidentical hormones can be FDA regulated. You see some of those listed there, or they can be compounded. Compounded medications, not FDA regulated. Compounded pharmacies, not FDA regulated. So not here to argue one way or another. I will tell you that FACOG, the American College of Obstetrics and Gynecologists, and ASRM, the American Society for Reproductive Medicine, are pretty outspoken about their opinion on it, and they reaffirmed it in 2023. Here you can see that the evidence is lacking to support the superiority claims of compounded bioidentical hormones over conventional menopausal hormone therapy. They say that customized compounded hormones may pose additional risks. They say do pose additional risks. And their concern, again, is because we don't know exactly what's in each tablet. So their concern is that someone might be overdosed or underdosed for their symptoms. Conventional hormone therapy is preferred over compounded hormone therapy given the available data. And evidence is inadequate to support the increased efficacy or safety for individualized hormone therapy regimens based on salivary, serum, or urinary testing. And this is hard with patients because I think, going and having their hormone levels checked regularly makes them feel like you're watching them more closely and you're doing a better job when, again, the science doesn't support that. So, making sure that your patients understand, if you're one of those doctors that is going to practice by the guidelines and practice, based on the research, or if you're one of those doctors that is not, and having that discussion. They for sure can find both kinds. So if they're not comfortable with the kind of medicine that you practice, they can for sure go, somewhere else and find it offered differently. But this is what's supported by ACOG and by ASRM. And we talked about some patients are not candidates for hormone therapy, and those are the ones where we have to be more creative and spend even more time with those patients. Up until recently, paroxetine was one of the few, up until recently, it was the only medication that was approved by the FDA that was non-hormonal for the treatment of hot flashes, and could be very effective in some patients. Clonidine can be used, off-label use, to treat some patients. It's a blood pressure medication, so, you need to make sure of who you're treating with this. But if they can't use, if they've had blood clots in their past or have coronary artery disease, and I don't think twice about picking up the phone and calling the cardiologist to talk to, about the patient, to say, this is Miss So-and-so. This is what I'm considering. This is an off-label use, but she's miserable. Is this something you're comfortable with? And documenting that approval. Gabapentin can also be used in some patients. Again, the research does not show that the phytoestrogens or the herbal supplements are efficacious. This is the medication that we've been waiting for. I have lists of patients that I need to contact. This is the one that's on your television screen. This is the non-hormonal medication that was designed to treat hot flashes. It just came out. It is not covered by most insurances, of course, and it is expensive if it's not covered. So again, we're a little behind the times. Hopefully our postmenopausal medication is going to pick up in the future as we become more outspoken. But for right now, first in its class NK3 receptor antagonist approved by the FDA within the last few months to treat moderate to severe hot flashes from menopause. It's 1 tablet daily, needs to be taken as close to the same day or same time of day every day. Cannot be used in patients with liver issues. They do recommend that you check liver function tests, do liver function tests before you administer this to patients, and that you monitor those every 3 months for the first 9 months that they're on the medication. So that's the blood work that the slide is referring to. Again, avoid it with known liver cirrhosis, severe renal damage, or end-stage renal disease. They do describe abdominal pain, diarrhea, insomnia, back pain, hot flashes. That's ironic. And elevated hepatic transaminases that can happen with this medication. I have not had the opportunity to treat enough patients with this. In fact, have not found any patients where it was covered yet that I can treat with this medicine. Again, it's just come out, and I see patients once a week. But hopefully in the future, it is going to be a big win for us and provide a lot of women a lot of comfort. So there's hope on the horizon. This is the number one complaint that I get from my postmenopausal and menopausal patients. Not even hot flashes, not anything else. It is vaginal dryness. I would have never guessed before I started treating this patient population. And again, I don't know if it's, because women are becoming more outspoken and more comfortable talking, with us about this issue, or I don't know, but vaginal dryness, vaginal itching, dyspareunia, and again, it's not even the dyspareunia complaint, it's the dryness and the itching that they come in and complain about, and I see this more than any other issue. So with this, start asking questions. The general H&P hasn't changed, so ask them, are you using any new soaps, any new lotions? Are you using any new lubricants or moisturizers? How long has this been happening? Are you itching all the time? Have you noticed sores? Have you noticed discharge? Don't forget, these women get infections too, and most of these women are sexually active, and they may not only be sexually active with one partner, and they may have a partner that is now deceased, and they have a new partner, and he may be seeing several ladies in the community. So, don't forget that these are normal gynecology questions, and just because we get older, those pieces and parts can change a little bit, but they can still get infections. So, talk to them about discharge, talk to them about odor, talk to them about partners. Could this be yeast or BV? Are they douching because of this? I had one lady that was doing an Epsom salts bath, sitting down in an Epsom salts bath every evening. All she had to do was stop that, and we didn't even have to talk about hormones. So ask them about their habits, but do consider infection. Also consider your vaginitis, your vulvitis issues. So like in simplex chronicus, you're looking at that is kind of that thickening. So when you look at these patients and talk to them, and I would say, absolutely, get the speculum out, take a look to see if there are any lesions, look to see if there's discharge, take a sample of that, send it off for studies. If you see this thickening, it could be like in simplex chronicus, which I have a hard time saying. You could also see the lichen sclerosis, both common in this age group. I think of one as being the thickening. The sclerosis tends to be a thinner, more you see kind of a dissolving of that labia minor and a whitening, thinning. They call it kind of a cigarette paper that can extend even down to the area of the anus. We see this more in women who also have other autoimmune issues, so diabetes, thyroid, things like that. It's also common when you have changes in hormones. So you can also see this in your young girls, in your teenagers, and then you see it more often in your older ladies who are undergoing menopausal changes. If you see these things, either biopsy them or send them to someone who can. Treatment for both is going to be steroids. The other thing we, of course, want to rule out is vaginal or vulvar cancer. And I think we tend to think of this more related to young women and HPV, when in fact it is more older ladies that are diagnosed with these issues in their 70s. So looking for any lesions that are bleeding, not healing, burning, itching, to rule out the bad stuff first. And then we get to vaginal atrophy. So if you've ruled out the infectious causes, ruled out the habits, ruled out the vulvitis, the vaginitis, and the cancer, then we may be looking at vaginal atrophy, which, again, dropping estrogen levels is a common finding. 10 to 40%. Research says, like I said, I see this in the majority of my patients now. They're going to have sometimes some discharge associated, some itching, pain with intercourse. The loss of the superficial epithelial cells causes a thinning of that vaginal lining. The loss of the vaginal rugae and the elasticity causes a narrowing and a shortening of the vagina, and you can see that and remember that when you're doing pelvic exams on these patients, because they are almost always going to take your small speculum, even in your larger ladies. You have a loss of subcutaneous fat in the labia majora that's going to cause a narrowing of the introitus as a whole. Vaginal pH becomes more alkaline, so that is going to predispose them again to those infections that we talked about, and they're going to have the decreased vaginal secretions, which again can predispose them to infections and certainly pain with intercourse. So what can we do for them? First line therapy is going to be localized estrogen replacement therapy. So these are the creams, the rings, the tablets, the ovules that they can apply Remember to talk about the way that they apply these. For some ladies, they are not comfortable putting a finger in their vagina. So when you're talking about how you're going to administer these things, talk about that. You know, can you take a clean finger and rub this into your vagina, or are you uncomfortable with that? Do we need to use something where you actually have an applicator, kind of like a tampon applicator that you use, that you can put the tablets or the ovules in? They often have to be careful with that because, again, the skin is fragile, or the inside of the vagina is very fragile, and so they'll have to do that carefully, but certainly those are available. This is also a therapy that is going to require continuous use. So it's not that they can take it and they're cured. This is something that they're going to have to use on a continuous basis, initially more regularly, and then maintenance. So typically they're going to start it every day, and then later on, hopefully, they could be down to maybe twice or 3 times a week. You know, one concern with this, and I put the Cochrane meta-analysis on here to remember to mention this, is, you know, we're talking about estrogen therapy. And so I didn't mention this when we were talking about systemic. Hopefully you remember that if you give someone systemic estrogen and they have a uterus, they also have to have progesterone. If they don't have a uterus, then they can take systemic estrogen alone. If you are applying it to the vagina, they can use estrogen only, even if they have a uterus, because the studies have shown that it is not associated with endometrial hyperplasia. Now, I will tell you, however, that if you have patients who have breast cancer or estrogen-sensitive cancers, it is not recommended by most oncologists that you use this, that you use estrogen topically, even on the vagina, because there is concern that there may be some absorption, and likely there is some absorption, and so we just don't want to take any chances with those patients. So breast cancer, can't use it, but otherwise they can use the topical estrogen without progesterone. And let's see. So then talking about patients who can't use hormone therapy, so for those other, for those breast cancer patients and the like, moisturizers are one option. So talk to patients, and next slide is talking about lubricants. So moisturizers and lubricants, 2 different things, also a little confusing, and they haven't done a great job clarifying this with marketing efforts. If they go to the pharmacy, hopefully the pharmacist can help them. But moisturizers are used more to rejuvenate and hydrate. Again, going to be a continuous therapy. I tell my patients, you know, you moisturize your face probably every night. You need to also moisturize your vagina. And when they're using these over the counters, they are going to be non-hormonal. So those are things that they can use every day. Again, taking a clean finger, massaging into the walls of the vagina, doing it multiple times a week. Or lubricants. Lubricants are more for the active intercourse, and so not something to be used on a daily basis. One thing to keep in mind when you're talking to your patients about lubricants, especially this population, is that you have to balance with the issues that are happening with their partners. So they need to be able to talk to their partners or consider the issues that are happening with their partners. Some of these lubricants, especially the silicone-based lubricants, are incredibly slick. The purpose of the lubricant is to reduce the friction. If their partner has issues of sexual dysfunction and erectile dysfunction, then using a silicone-based lubricant may eliminate their possibility of effectively having intercourse. So something that they need to be open and discuss with their partners, and it needs to be a careful balance of comfort for the lady and comfort for their partner. And finally, you will have patients that ask you about, you know, the latest and greatest vaginoplasty, vaginal rejuvenation. I can't even think of all the different ways it's promoted and said these days. But there are a multitude of options of surgical therapies out there. Again, ACOG committee opinion says that surgeries or procedures to alter sexual appearance or function are not medically indicated, pose substantial risk, and their safety and effectiveness have not been established. So just something to keep in mind when you're talking with your patients and asking the question or answering the questions. Also, one of the most common patient issues would be the fact that they are doing everything they can and they cannot lose weight. And again, not something to be dismissed, supported by science. She is not sneaking donuts and not telling you. Certainly, our estrogen affects our glucose homeostasis, our insulin sensitivity, the body fat distribution, and so everything that we do and the calories that we consume change when our estrogen levels drop, and the science absolutely supports that. And we know that as women become more obese, it can affect all other aspects of their health. Breathing problems, sleep apnea, heart and blood vessel disease, the number one cause of death in women in this age group, leading to type 2 diabetes, cancer, all of those things. So the weight issues that they're expressing are not simply based on, that they want to get into the latest and greatest bikini. Sometimes it's truly a medical issue and has to be taken seriously. And I think the best way to talk about this with them is they're right. It's not fair. Their husband may be eating exactly what they are, maybe doing, or eating twice as much as they are. He's losing weight and they cannot lose weight, and they're working out in the gym, 2 hours every day. We absolutely know that this is the case. Studies have shown that in order to maintain the weight that you had at age 30 or 40, at age 50, your calorie balance should be 200 less per day. So you have to do a lot more, eat a lot less, move a lot more in order to stay at that same weight. It's not, you're not imagining it, they're not imagining it. So have the serious conversation, the honest conversation. You can't help it. There's nothing else you can do about it. We have to move more and consume less. And hopefully as we begin to talk more openly about these things, again, we can better prepare women that this is going to happen and that we can, address it honestly and adjust. Urinary incontinence is an issue that patients don't usually bring up on their own, and something that you have to kind of directly ask them about. Every patient that comes into the office, I ask them, do you have issues of urinary or fecal incontinence? Are you losing, urine when you laugh? Are you having to plan your trip to Publix around how you get to the bathroom or how long you can stay? This is not typically something that they're going to bring up on their own. So ask that question, and then again, ask more questions. Talk to them about, how long it's been going on, how bad is it? And number one, ask them, are you wanting to treat this? For some women, they are comfortable with the level that they're having, that they occasionally cough and they will have some leakage. For other women, they're wearing a pad every single day because it happens so often, and they may be willing to make some changes. There are options for treatment. I find, this is talking about, one thing you can do when you're talking to them and asking the questions, do a physical exam, screen for infection, so sometimes that will increase their risk. You can look at post-void residuals, cough stress tests, urodynamic studies. You can refer them to a urogynecologist that can do these studies for you. And then looking at treatment, looking at behavioral and lifestyle modifications. So for some patients, they think if we talk about this, then she's going to send me for surgery. Not the case. There are a multitude of things that you can try first. Some of them as simple as starting with the basics. Get back to the Kegel exercises, every day before you get out of bed, 25 times, or at night when you're trying to go to sleep. going back to things like estrogen therapy can help those tissues to be stronger. Bladder training, weight loss, kind of the simple things can sometimes help. Medications can be effective for some patients. They do have oftentimes side effects. The antimuscarinics that we used to use more have a lot of issues with the dry mouth, the dry eyes. The beta agonists now are much better about that. They do help to relax those muscles, extend that bladder capacity. There are the injections of the botulinum, and this isn't about wrinkles on their forehead. These are injections to help with paralyzing those involuntary contractions that can cause emptying of the bladder. Neuromodulation, if it's available to them, can be great. This is, in layman's terms, they go in and there are stimulators that help to build up those muscles and make them stronger in the pelvis. And lastly, if all of those other things fail, certainly they can talk about their options for surgery. So a multitude of options out there for these ladies if they have a problem and want to seek treatment. Vaginal bleeding, something else, ask the question. I will never forget, I asked the question and the patient told me no vaginal bleeding. We did her pelvic exam and there was blood in the vault. And I said, "Are you sure you don't have any vaginal bleeding?" No vaginal bleeding. So we talked about it. I said, I'm not going to sleep at night until you go see somebody and we get an ultrasound. We got an ultrasound and she had thickening of the endometrial lining, irregular thickening. She went for a biopsy. She went for a hysterectomy. She had endometrial cancer. And she had not even noticed the vaginal bleeding yet. And I'll never forget looking at the referral note back from her surgeon where it said, the patient says that her gynecologist insists that she has, that she is having vaginal bleeding, but the patient insists that she is not. And thank goodness, I kind of stuck to my guns in that patient. But ask that question. I think as women, for so much of our lives, we have bleeding and spotting that happens that it just becomes kind of the normal course that you think, okay, well, that happened this morning, something crazy, but, maybe it'll go away, and you get on with your busy life. And unfortunately, in women who are postmenopausal, so after that 1 year of no bleeding, they should have no more bleeding. Any bleeding after that point can absolutely be a sign of endometrial cancer, and they need to come in and talk with you about it. And so every visit, even if everything's going fine, they have no complaints at all, I think we should be reminding our patients, any bleeding at all after this. And sometimes I'll tell them, I'm doing a pap smear today, and especially in postmenopausal ladies, when you take some of those cells off the face of the cervix, it doesn't always like it, and sometimes they're going to have a little spotting that day. But, remind them, you might have a little spotting today, but any other bleeding, not normal, you need to be calling me, and we need to be looking into this. So evaluation, I mentioned medical history, physical exam, ultrasound, looking at the thickness, because again, they should not have enough estrogen to be growing a thick lining that they're going to shed and that they're going to bleed. If it's greater than 4 millimeters on the ultrasound, certainly somebody needs to be doing a biopsy and looking into that. Endometrial biopsy is something that some of you can do in your offices, or you can send them to the gynecologist or to a GYN surgeon. You can let them know. They'll do that in the office. It is tolerable. It's not fun. It causes some uterine cramping, lasts a few minutes. They go home the same day. It's going to tell you about the tissue inside the uterus. Some patients do require a little more aggressive look, and that would be a dilation curettage or a DNC to kind of scrape all the tissue out of the uterus to look at that. And then if any sign of endometrial cancer is there, certainly they're going to need surgical staging with a GYN oncologist. Endometrial cancer, it is the most commonly diagnosed GYN malignancy. Mean age of diagnosis, again, it's this population, 63 years of age. It is more common in Caucasian women. Risk factors are those women who have been exposed to more unopposed estrogen. So if ever in their life, they were taking systemic therapy and just thought they didn't need that progesterone anymore, if they had polycystic ovarian syndrome, those young ladies will often go many years and not have periods and think that's just great, but in the meantime, that endometrium is growing and thickening and can develop cancer. Nulliparity, early menarche, late menopause, all of those things can contribute to a greater risk of this. But most of all, any bleeding after menopause needs to be checked out. Bone health, and I'll try to skip through some of these things more quickly because hopefully these are the basic maintenance things that we're all aware of. We know that as we get older, estrogen supports bone. As we have less estrogen, our bone resorption exceeds our bone building. There's a gradual deterioration of the strength of the bone and of the bone mass. Osteoporosis becomes more prevalent as we get older. It's more prevalent in Asian Americans and thin white Caucasian ladies, least prevalent in Black Americans. We look for osteoporosis with bone density scans starting at age 65, sometimes earlier. So there are tools that you can use. FRAX is a good one to decide if you need to be looking at these things earlier. With osteoporosis and the bone density scan, you're looking at the T-score, so that's the comparison of a woman's bone density to that of an average healthy young woman. And these are looked at in standard deviation. So a T-score of minus 2.5 or less is going to be osteoporosis. It can also be diagnosed clinically by looking at a patient who has a fragility fracture, and so that's obtaining a fracture at less than a standing position. Then you should be concerned. Risk factors, again, thinness, advanced age, smoking, again, another good reason to stop smoking, excessive alcohol consumption. I am amazed in my postmenopausal population. Again, these are predominantly retired ladies that I'm seeing, and they drink a lot of wine. Hardly ever do I see a patient that doesn't drink at least 2 glasses of wine a day. I guess, they don't have to go to work tomorrow. So they are drinking a lot of alcohol, and so kind of, again, a risk factor to think about. Diseases, your people who aren't absorbing well, your people with thyroid disease are at greater risk, and drugs, certainly, we always think about our steroids, our GnRH antagonists, things like that can be risk factors. Big things to think about: lifetime risk for hip fracture. It's 17% in white Americans, 14% Hispanic, Black Americans 6%. This increases their risk of mortality 25% for the remainder of the year if they have a hip fracture. And unfortunately, I have to bite my tongue so many times because I'll be talking to friends or relatives and they talk about, oh yeah, Aunt so-and-so, just fell yesterday and broke her hip. And I'm thinking in the back of my mind, oh no, lay people don't know how bad that is and what a significant risk factor that is. And so with bone breakdown and osteoporosis, we're at much greater risk of hip fractures and certainly of death. So something to keep in mind. Routine aerobic physical activity, weight-bearing exercise, this. Calcium and vitamin D, the daily allowance of dietary calcium and vitamin D is currently what is recommended, not necessarily supplements. And certainly if osteoporosis is identified, they should be treated with medications. And at least in my case, usually I refer them to an internist who would follow that. So other routine screening, mammogram. Hopefully I did not spend a lot of time on this because I think it is one that we all recognize more readily. I'd say one of the biggest things there is the new, comment on dense breast tissue. And if your patients, if their mammogram comes back and it mentions dense breast tissue, we need to be talking to them about the fact that the mammogram may not be as effective in women who are identified to have dense breast tissue. Currently, the research doesn't support subsequently, automatically sending them for MRIs or follow-up studies yet, but it is our job to at least talk to them about that dense breast tissue and not just, send off that letter that says mammogram was normal, we'll see you in a year. Because I think hopefully it makes them be better about doing their breast self-exams and paying attention. Colonoscopy, of course, still every 10 years. And then finally, pap smear, which is a little more confusing in this patient population. Like I said, 50% of my patients don't need pap smears now. Still recommended that they have a GYN exam, that they have a pelvic exam. Remember, we're looking at the vagina, we're looking for the vulvar diseases, all of those things that they can't easily see on their own. But the pap smear beyond age 65, if they have normal screening prior to that, normal screening being 3 consecutive normal tests that are pap test alone, 2 consecutive normal tests that are pap HPV co-test, and again, not having a significant history of abnormal pap smears. If they do, and you have that discussion, I feel comfortable continuing that pap smear if they want it, and it tends to be covered as long as you document that. If they have a hysterectomy prior to age 65, then typically, if that uterus is removed for a non-cancerous reason, then they don't need a pap smear. So I explained to my patients that I'm still going to do a speculum exam. We're going to put that speculum in. We're going to look at those tissues because, again, you're at increased risk of vulvar disease, of vaginal disease, of cancers, but we don't have to do that swipe with that brush that causes you that cramping and send that test off. So that's what they get to grow out of with either that hysterectomy or age 65. So the question that I then get is often, well, if I don't need my pap smear, do I really need to come see you at all? And I don't think they have to see a gynecologist. I do think they need to see someone that's going to do a gynecology exam. And, at least in our office, the internists and family practice doctors are honestly a lot busier than I am because they're responding to, the lady that called with possible COVID symptoms and, this and that. And so I'm a little more available to take the time to talk about the stuff that we still need to talk about in these patients and to do those exams. So we've started kind of dividing it up that if they have gynecology, if they see women, then I tend to get, the GYN referrals. And so if you have a gynecologist in your area, you may want to, to try to refer to them just to kind of buffer your schedule a little bit. But most importantly, remembering that, menopausal patients and postmenopausal patients have issues. And hopefully, again, we're a generation that's going to feel more comfortable about talking about them. We're going to demand that people start looking at them and doing more and more research and finding solutions. But on the other side of that, I think that as physicians, we're going to have to be better prepared for these very smart, intelligent, outspoken women to start asking us a lot of questions, and we better come up with some answers quickly. They want to feel better. So thank you for your attention. I know it's late in the day. I was trying to get through a lot of information, so hopefully you were able to get something out of it, and it will be helpful to someone.
Thank you for a wonderful presentation.
Thanks.
That's such a big component because a lot of women don't talk about menopausal symptoms. I had one patient who said she went to church and the lady who was directing said, "This lady has the vapors." I had never heard that before.
Yeah, I've not heard that
so
one.
I'm teaching you the vapors. But funny thing I wanted to mention, and Linda's here, who's one of my nurse practitioner students. We had a patient last week who said it's a joke really, just mental pause is what she called it.
Oh, yeah,
And I just thought it was the funniest thing, because a lot of women will complain about this fogginess.
Yeah, for
or
sure.
their memory not working well, and so we really have to listen to their issues, and you did a great job of outlining what the
thank
problem
you.
areas are, so thank you so much for that, and let's
Thanks.
take care of our ladies, because we just don't talk about it enough. People
Yeah.
are so scared of hormones, they don't mention it,
Yeah.
when there are other things that we can do, and so thank you for really spending the time to talk about this area.
Thank you for having me. Yes.
Hi, I was wondering, how do you counsel patients, or how do you make the decision together about when to stop taking birth control?
Yeah.
And does that mask the symptoms of perimenopause at all, or premenopause?
Yeah. So I think absolutely it can kind of mask those symptoms because it's systemic hormone replacement. And so I think what you have to think about is as women approach their 50s, is it safe for them to continue to take hormones at that level, at the level of the birth control pills? So even like your low estrogen, I think at age 50, 51-ish would kind of be when I would start talking to them about switching them over to a low-dose replacement instead of the birth control in most cases. Is that anybody else in the audience? That's kind of my break. And that's my personal gynecologist's break when she sat me down. So is that kind of where you are as well?
And it's really hard because a lot of women are really terrified of being pregnant.
Yeah, yeah.
I had one patient, her husband was 80, and she said, I have to have birth control. So it's important to be sensitive to
Yeah.
the partner, and I love that you mentioned the partner as part of your conversation. But usually we're transitioning around 50, 51.
Yeah. Yeah, I think it just becomes safer. And another thing I talked about that patients won't always, you have to like dig it out of them that they had a blood clot. But the other thing is, I ask, do you smoke? And no, I don't smoke. But I vape every day. And it's amazing what they just don't tell you. And then you're the one with your name on the prescription. So, it's unfortunately very much our job to try to, in the very short period of time that we have to spend with these ladies, to really tease the important stuff out of them and kind of, I feel like sometimes I kind of have my little routine, and I don't know if anybody else feels like that, but I think that also, I remember, in surgery, our GYN oncologist saying if you have a routine, when things go badly, you don't get off course. And so that's sometimes the way that I feel, that if I kind of have my questions that I ask every single time, then hopefully they won't tell me about their grandson and his puppy dog, and I'll forget to ask about, are you having vaginal bleeding? Just kind of have your set questions that you make sure that you ask every single time.
And I love that you mentioned the blood clot. So in the history taking, I specifically asked that question because it gets forgotten
Yes,
often.
absolutely.
And so you learn the questions that you have to ask because they may have intermittent amnesia.
Yeah.
Right?
Yeah.
Which can be harmful.
Yeah.
Hello.
Hi.
Do you see more women who decided to become sterile, like they've gotten the tubes tied or had to get a hysterectomy? Do those women start menopause faster than the ones who chose to keep their going,
To keep their
tubes tied or
Right.
get a hysterectomy?
Yeah. I have not seen that. Have not seen an association between a prior tubal ligation or hysterectomy where the ovaries were retained in them. I see how that could happen in some ladies, certainly, that blood supply, depending upon how the surgery went and what happened. I could see how theoretically it could happen to minimize the blood supply to the ovaries, but I haven't seen that. And in fact, even back to, my days when I was treating fertility patients, I didn't see that the egg-making ability or ovarian function was impaired if they had a history of a bilateral tubal ligation or even a hysterectomy either. So,
is there harm in removing the uterus?
is there harm in removing the uterus? Was that the question? Not typically, and typically we remove the uterus because there is a problem. So I guess, I should answer that a little differently. I wouldn't remove the uterus for no reason, because any surgery can bring about risks. But if there is a history of consistently abnormal pap smears that can't be resolved, or certainly signs of endometrial cancer or large fibroids, leiomyomas that are causing excessive bleeding, and in that perimenopausal age group, sometimes these women will have horrific bleeding that can't be resolved hormonally or with the IUDs and endometrial ablations. And in that case, sometimes risk versus benefits, it is, to their advantage to have that uterus removed. And, if they keep their ovaries, even if they're, younger, then they continue to produce hormones. Certainly it's not the uterus that's producing the hormone, it's the ovaries. So hopefully that answered your question.
I just have to say, I don't want to embarrass you, but this is an outstanding young man. He's our youngest symposium event participant ever, and it's just been fantastic today. Keep thinking about taking care of people.
That's
We want
right.
to see you in a white coat.
That's right. And taking care of women.
That's right.
So, a question?
Yes.
Today we know that ovarian cancer originates from fallopian tubes, and maybe there is advantage to remove fallopian tubes before menopause. Do you have any comments about this?
Yeah, I think certainly that is something that has changed over the years, because we used to think that the fallopian tubes, I don't know if everyone kind of heard that question about the fallopian tubes and them contributing to cancer. We used to think, they were just mechanisms of transport and they were benign, and, the ovaries could be bad and the uterus could be bad, but the fallopian tubes were just the innocent party. And we now know that that's not the case. And so I do think that if you're having surgery in that area for other reasons and you've completed your childbearing, that surgeons are considering removal of the tubes more readily now.
My second comment or question is about premature ovarian insufficiency. And I think the biggest group will be younger breast cancer patient. So if there is history, right now we have so many different chemotherapy and targeted therapy. If there is a history and it's something that is monitored, if breast cancer survival, younger breast cancer survival remain with their menses, or they lose ovarian function?
So I think your question is about what do we do for young patients who develop, who are developing breast.
My question, there are certain chemotherapies that are very toxic to ovarian function.
Yes.
But there are newer
Yes.
targeted therapies, but we don't even know how they affect ovarian function. So I'm really, as a scientist, I'm very interested in this. Who would have this information? They are oncologists, they are gynecologists, or no one at all?
Yeah, so very rarely is there an oncologist that spends a lot of time with those patients, talking to them about preservation of fertility at that time. I say that as a former fertility doctor, because most of the time when the patients came to me, there were occasionally oncologists that would refer to them, but despite the fact that I told all of the oncologists in the area that, if you have a young patient that's going to have to start undergoing chemotherapy that can affect her ovaries, I will see her, call me. I'll see her on the weekend, I'll see her in the evening, you know, I will see her, I will get her in, because clearly in those women, it is an emergency to get them started on treatment as soon as possible. And the best method that we have to protect their ovaries at this time is egg freezing. And unfortunately, the majority of those patients, even if you help them financially, and the hormone companies are great about dedicating and donating medications for them to actually undergo stimulation and freeze their ovaries, freeze their eggs. Freezing eggs better than freezing ovaries. Most of those patients don't take advantage of it because they are so overwhelmed by their new diagnosis and so afraid that they're about to die that they cannot even think about their reproductive future, which is very unfortunate and sad, and something that we need to work to make better. But right now, the people that spend the most time working on those patients, talking to those patients, is the fertility doctors, your reproductive endocrine and fertility specialist, REIs in your area. And typically, I would call the oncologist and say, hey, I want to talk to her. How much time do we have? And try to work with those patients. But I mean, probably a handful of patients in my entire career that actually took me up on it. The other best means of trying to protect the ovaries is basically putting them to sleep. So giving them a GnRH agonist that basically stops their cycles, and you hope that it protects their ovaries as much as possible. They just aren't as active and they don't absorb as much of the chemotherapy. And we did see that in some of those patients, they would eventually resume menses, and some of them did actually get pregnant on their own. Not very effective, pretty rare that we had that wonderful surprise, but that is probably that's what patients use more than anything. Unfortunately, they don't often freeze their eggs, but they will at least use the GnRH agonist. And again, often you can get that donated by companies. Hopefully that answered your question. Other questions? Thanks, y'all. I know it's late in the day, but thanks for paying attention to menopausal medicine.